Today, I'm going to be talking about the science and the technology supporting grafting materials. And of course, that has to do with alveolar ridge preservation and regeneration. We know that this is an integral part of implant dentistry. It's a requirement. We cannot do good implant dentistry nowadays without proper preservation of the bone structures and also regeneration whenever it's missing. The problem with that I see is that not always this regeneration or this preservation is done properly. I think material selection plays a big role in the success or the long-term success of regeneration. And the problem that we're starting to see now as becoming epidemic, in my opinion, has a lot to do with poor material selection or poor quality of certain materials. So this is a case that was a rehabilitation that a patient had done 2 or 3 years prior to this surgery here that basically resulted in the removal of 2 implants initially. The third one was also removed later, and also loss of 2 teeth as a consequence of fast and progressive bone loss around the implants that had been placed recently. So that's the big problem that we have with alveolar regeneration or preservation of alveolar bone. If not properly done, it may result in a residual osseous structure that may not have the ideal potential to fight trauma or injury or infection. So when it starts, it's just like quick fire. It will take a lot of that bone away, and it may lead to a failure of the reconstruction. So just a couple of years ago, Dr. Murray came up with the concept that we still use on a daily basis. Okay? This is where all our regeneration comes from. Back in '57, Dr. Murray showed that when you have an osseous cavity that was isolated from soft tissue through a membrane or a device that isolated, you could have complete formation of bone within that cavity. While when you didn't have this soft tissue isolation, that led to fibrous connective tissue invasion. So that's pretty much what we do nowadays. We're always fighting for the invasion of the soft tissue. We're fighting through different methods. It doesn't need to always be a membrane. A bone graft will also have the capacity because it's occupying a space that soft tissue would normally use and invade. So that's basically what we have nowadays. We have 2 ways of dealing. Either we separate with a membrane or we use a bone graft to accomplish that. And the reason why we use bone grafts and not just membranes is this. A bone is just like my 14-month daughter. She's a very good crawler, but she's not a very good jumper. Okay? So keep that analogy in mind. Bone cannot jump and close a gap. Bone needs something to crawl against or to migrate against. So what the graft particles do is exactly that. They help initial bone formation by allowing osteoblasts to migrate from one cell to another. And we had an outstanding video here before showing the importance of collagen on all of that. So once bone is able to bridge the gap, it's important that those graft particles go away. Otherwise, they're just occupying space that could be used for further bone formation. If they just sit there and occupy that space, they will stop further bone formation, and what you're going to end up with is maybe a nice volume of bone, but without the adequate quality. And that may result in something like I showed before, in a situation in which you have some trauma and all the bone resorb very quickly. So what kind of graft materials are available in dentistry? Roughly, we can classify them as autografts. We also have xenografts, alloplasts, allografts, and also biologics. The autografts are the autogenous tissue that is basically an auto transplant. Xenografts come from different species. Alloplasts, synthetic materials, and allografts from the same species. We also have the increased growth of biologics now that may help this process of bone formation. We also use membranes as a method to separate the soft tissue from the wound, and we can classify them in either absorbable or non-absorbable. Absorbable membranes can be divided into fast and slow resorbing. and I think it's important to understand that. A lot of the barrier membranes that are available in the market, they came from guided tissue regeneration. When we were regenerating periodontium around teeth, we wanted barrier membranes that would not last too long. Otherwise, it would promote ankylosis. That's why the EPTFE membranes were removed anywhere from 4 to 6 weeks. So the resorbable membranes were also developed for that. A lot of these membranes have been adopted and are now being used for implant dentistry, but they don't have the property of lasting long enough for that bone to mature. So slow resorbing membranes are more indicated for GBR. We also have absorbable membranes that have some tenting capacity, and the only one available in the market nowadays is Curve. And we also have the non-absorbable membranes that can either be titanium reinforced or not. It's important to understand that we also have tenting devices available in dentistry nowadays that do not have a barrier function, so they do not exclude the soft tissue. So that would be like the titanium mesh or cages or PGA and PLA plates that have also been used, and bone pins as well. So what are the major limitations that we have, or that we have with the current grafts that we have available? Autograft, of course, is always donor site morbidity and limited sources. Xenograft, is low turnover, delay healing, alloplast, fibrous encapsulation, and for allografts, disease transmission and tissue rejection. We know that that has been well controlled with the current processes for allograft tissue use, so that's not so much of a concern anymore. And of course, the big advantage is that we have unlimited sources of material because it is commercially available, and the market only grows and grows every year. So looking at these materials, what properties do we need for that graft to actually exert? We have osteogenesis, which is the most desirable property, which is the graft itself can form bone. Okay? That is a property that only happens with autograft, or autogenous tissue has that capacity, because that's the graft that will have osteoblasts or living osteoblasts, or for how long they're still alive. Osteoinduction is when the graft can induce the formation of new bone. That is also something that can only happen with certain proteins. And that's a feature of biologics. Biologics are fulfilling this gap for us nowadays. But largely, all the other graft materials, what they do is osteoconduction. So as you can see here, the only ideal and still considered to be the gold standard material is autograft, while the other types of bone grafts that we have available, they always have some limitations. So at the same time that biologics have the capacity to induce bone formation, they lack osteoconductive properties. So that's why they have been used nowadays in combination with some type of an osteoconductive matrix or a bone graft material. So another aspect that is very important in bone grafts is particle size. Particles, there's an ideal particle size depending on the type of defect that is being treated. So for example, extra small particles are considered to be less than a millimeter in size. A lot of graft materials that you buy nowadays, especially those that are not the most expensive ones, normally the cheaper ones, as you see on the base of the plate, you're always going to see a lot of powder. Okay? That powder is just leftover of the crushing methods that they use to grind those particles in smaller pieces. And a lot of times they add to a lot of the weight of the graft that you are actually buying. What's the problem with that? We know that those really small particles, they have problems with, they don't have a lot of mechanical properties because they get washed out very quickly. They also have a capacity to be over-compacted. So you almost tend to overfill the defect too much when you use those small particles. So the best products should have a constant size of particles or for the size that you buy. So for example, if you want to have something on the small side, you want to have as many particles as possible from 0.5 to 1 millimeter, and not a lot of powder or not a whole lot of large particles that will come with it. Otherwise, it will make the application of the product very difficult. Okay? Extra large particles are not so much used in dentistry, while the large particles seem to be applied into sinus cavities or defects like that. So let's start talking about autograft. Autografts can either be intraoral or extraoral, and this is where everything started in guided bone regeneration for dentistry. This is a type of technique that fortunately it's not as common anymore, but still practiced a lot in many countries and in many areas in the world. There's a big reason why implant dentistry gained the popularity that it has nowadays. It's because we don't have to do this anymore. While searching the literature, I found that some authors claim that this is a very predictable and safe procedure that only leads to about 12% of meningitis after treatment. So I'm glad I don't have to deal with that problem. So I've never used an extraoral source for bone grafting, but I've used a lot of intraoral sources, and I think it's a beautiful technique. It's way safer than a lot of people claim. Of course, if I could give to my patient to decide to either have an autograft or have an allograft block, I'm sure they would all prefer an allograft block, but it does work. It can be considered safe. It allows for adequate regeneration, augmentation of deficient sites, and adequate placement of implants. What you always like to see when you place a graft, especially a block, is to see the disappearance on the interface of the block. If there's still visible interface, that means that there's not a whole lot of turnover happening in that area. So if you look at this picture here, there's some leftovers of that cortex on the buccal side. That is the part that has not turned over yet, but close to the recipient bed, a lot of turnover has happened there so that you can't identify that gap anymore. What about xenografts? We know that comes from different species, and the most commonly ones here in the US are bovine or equine. We don't use canine here, fortunately, but in some countries they have used that. So how does the FDA look at xenograft? They look at it basically as, they classify it as either concordant or discordant. Concordant would mean that the species are closely related, okay? And discordant is if there's a big discrepancy with the species involved. So bovine to human, according to the FDA, is considered to be a discordant association between the graft and the host. What's the significance of that? If this was applied without processing, this would lead to a hyperacute infection that would be basically resulting in a complete loss of the graft within hours of application. So the processing is done to prevent that from happening. And as a consequence, it denatures bone to a point that what is left is basically just a crystal with no collagen whatsoever. And this process is called sintering, which is bringing bone to extremely high temperatures. That will completely denature all the protein content, and we'll be left with the crystal, which is just the mineralized component of bone. And as a consequence of that, what you have is a good osteoconductive material, but without a lot of binding mechanisms to new osteoblasts. So that's the main limitation of xenografts. They have to be processed that way, because if they're not processed that way, you're going to have the major reaction. The other significance of that is because it dries too much. It has a lot of density. So there's virtually no remodeling over time. As you can see here in some clinical applications, there are some good uses for this type of material, especially when you need to maintain the space, when you want to keep the area or the defect filled for a long period of time. And a good example of that, it would be a sinus augmentation procedure. So in this case here, you can see from before and after, a significant augmentation was the result of this surgery, that now an implant can be placed there without a problem. What about alloplasts? Alloplasts are not very common in the US, but very common in other countries, especially in Asia. It's very common because of regulations that allografts and xenografts are not allowed in those countries. They use a lot of alloplasts. Alloplasts are basically synthetic materials, and that can actually be derived from coral as well. And what you have is a hydroxyapatite, calcium carbonate, calcium phosphate, different types of products. When it's a completely synthetic product, they can actually modify the amount of porosity that a material has. So if you add porosity to it, it actually has a very high resorption rate, almost too high. If you take away all the porosity, it will last as long as a xenograft would. So that's the reason why this has been used in different applications as a delivery system for growth factors. A good example of that would be the PDGF growth factor we have available in the market. We use tricalcium phosphate as a delivery system. A lot of people throw that away and they mix it with the normal bone graft, but the normal bone graft cannot absorb that protein. So if you don't have a delivery system that can deliver the protein in the site, that protein tends to be washed out very quickly. So this is an example of the high-density synthetic material that does not turn over. Okay? So this is 6 months after site preservation. Patient comes to you. Radiographically, it looks fantastic. It looks like you have the hardest bone in the world. You open a flap, and you start to dig in. It feels kind of soft, and you clean all that up, and then you still have a socket in place. I think that gives a completely new meaning to the word socket preservation, because basically that nothing has happened to that socket over time. So it prevented bone formation. Instead of helping bone formation, it prevented bone formation. So this type of material can actually be used successfully as a filler, but not as a graft material by itself. So finally, let's talk about the ones that we use more often and the ones that we like more. And we like them more because they work better. They're closer to what autogenous bone would be, and without all these drawbacks that some of the other materials may have. So allografts can be divided depending on the process that it's applied to them, as well as the type of particles that you are purchasing. So allografts can be demineralized, and normally when they're demineralized, you have both types of particles. Because it's demineralized, it doesn't matter anymore. But you also can buy them into either cancellous or cortical. There's a big difference between cancellous and cortical. Cancellous particles, they tend to turn over much faster than the mineralized cortical particles. And overall, they have much better features, so much better properties, better handling, better mechanical properties in terms of space maintenance and also density. So the cortical particles may add a little bit more mechanical property, which means space maintenance, largely due to the higher density that they have. So the combination of these properties, in my opinion, can lead to a better clinical outcome. So what are the different methods that are used to process allograft materials? The general processing methods are basically the same for all allografts available in the market, which is the traditional FDBA, or the freeze-dry process of allografts. The sepsis is based on antibiotic rinses. It's followed by liquid nitrogen that freezes the material, and that basically breaks down collagen. And then the lyophilization process, which is not so closely related to sintering because the temperature is a little bit lower than that, but still like really high heat. That is basically done to remove all the residual moisture within the particles. And that allows for reduced immune response by the host, as well as improved shelf life. Of course, if you demineralize, if you have a DFDBA type of product, there's an additional bath in hydrochloric acid to remove all the mineral content from bone. The only other material that has different processing is Puros. Okay? Puros came into the market about 6 years ago, and what's different about Puros is this Tutoplast process. This is a patent process that instead of using the high heat that is normally used with all FDBA type of products, it's just a series of baths. It's a really slow process. It takes a couple of weeks for this to be completed. And at the very end, the material is actually sterilized under low-dose gamma radiation. The big difference here is that collagen is preserved within the particles. We all heard today in different lectures that collagen is really important for early osteoblast attachment and further differentiation, proliferation, and new tissue formation. So the preservation of that really allows for a more uniform or faster activity of those cells that need to grow into the defect. This is just some early histology that we published in 2006 that really shows the faster turnover of these particles and the easy or very close communication with host bone and those particles. So what does that mean clinically? How can you define that clinically? Because you're not going to be taking core biopsies in every single patient that you see. Clinically, that means this. This is the residual defect that a patient had after an extraction and in inappropriate site preservation that had to be completely degranulated. But there was still enough bone for an implant to be placed, so implant was placed, and the graft was applied around the defect. Flap was covered up, patient was allowed to heal. Patient comes back 4 months later, and not only the bone has grown around the implant, but also over the healing cap or over the cover screw. But as you can see in this picture here, you don't see residual particles. What does that mean? That means that the bone that has formed there, the bone that you see now, is new bone. It's not just bone that grew around particles that are sitting there and occupying the space. So turnover is the key. You want that graft to help the initial healing, but you want it to go away. Because if it stays there, you're going to have a limited outcome. So what are the applications of that, or all of that I just talked about? It has to do with ridge defects. We know that ridge defects have different shapes. There are different clinical situations. Some have more walls than others. So your material selection should be based on that. What kind of shape does the defect have? What kind of healing potential does it have? If you look at the different defects that we have available in implant dentistry, or we normally face in implant dentistry, you have the 4 or 5 wall defect. That's the one that has good regenerative potential, had good mechanical properties because by itself it can maintain the space, has the best vascularity. So that's the one that we all like to treat, but unfortunately that's usually the one that we don't treat much. We treat the most challenging ones, the 3 wall, the 2 wall, and the 1 wall defect. So your selection should be based on that. So let's give some examples of the 4 and 5 wall defect. I believe that when an extraction is properly done and all the walls of the socket are intact, to a lot of very conservative approaches, you can end up with a very positive outcome without using any type of bone graft, okay? So this is a study that we published in 2011, almost 2 years ago, in which we basically just extracted the tooth, allow a blood clot to form, cover it up with a long-lasting collagen membrane, and allow it to heal. 12 weeks later, we came back and we took like a flapless biopsy of the area, and in 90% of the sites, we found complete bone formation at 12 weeks without a single particle of graft. So I think that this is a good example of why we should be a little bit more careful on making a decision on when to graft and when not to graft, okay? I think if you're treating the premaxilla, it's one story. We worry about aesthetics, we worry about other things. But in some areas in the mouth, I have a hard time understanding the need for site preservation, okay? I work in Gainesville, Florida. Half of my patients live on food stamps. So the difference between putting a bone graft in a socket or not, it's probably the difference between this patient having money to fill up getting a tank of gas or not, okay? So you have to be careful about it. There are a lot of situations in which you may not necessarily need to do that. There's another example of the 4 and 5 wall defect. This is a much bigger defect. It's a sinus cavity. Here is where I think xenografts can actually work very well because of the ability that they have to maintain this space for a long period of time. This may allow for a more progressive healing of that site. We have to remember that there are 2 steps of healing here. We have the first one when the surgery is done, the second one when the implants are put in. So that may allow for some remodeling of that material, but being able to maintain the space over a long period of time is definitely a desirable feature that these materials have, much better than allografts, for example. What about 2 and 3 wall defects? Good examples would be either the damaged socket or the dehiscence type of defect. Those are the tough ones to treat. And I still treat this with the same technique that we published in 2004, which is we call the sandwich technique, which is a horrible name, because this looks nothing like a sandwich. It may look more like a pita or a taco or whatever, because it doesn't have 2 layers that look exactly the same on the outside and on the inside. Anyway, if you want to understand more about the different properties of materials, read this paper. We describe the reason for layering grafts instead of just mixing them together in this paper. And basically what this technique does is we combine the fast resorbing materials with the slow resorbing materials, and we cover it up with a membrane instead of mixing them together, just using the different properties. Nowadays we have better tools for that, and I think that this is a good example of this technique. If you look at these extraction sites here, very complex. The lateral had a history of periapical or apicoectomy, and that's why you have this deeper concavity on the apex of the lateral. The canine is gone, no buccal plate, even some communication with the premolar. So in this case here, we layer purus cancellus over purus cortical, cover it up with the copiose membrane, a long-lasting resorbable membrane. That's my favorite membrane for GBR. Cover it up, allow it to heal, no pressure over the wound. And patient comes back at 6 months later, 4 months later, and that's what you have back there. So if you see a before and after, I think it's a very significant outcome without the need of any expensive materials or techniques. From a buccal perspective, you also before and after, I think we have more than enough now to place an implant in an adequate way. I think what's important to see here too is not only you have the volume, but you can clearly see the particles of the graft, and that really shows that there's a lot of turnover going on here. Chances are that what you have there is just new bone that has formed. What about the tough defects, the one-wall defects? I think that this is where we need something that will work as a block. Does it always need to come from the chin or from the calvaria? Not necessarily. I think the same technology that they have used to create this particulate bone that is very successful can also be used for blocks. So those blocks that are processed the same way in the premaxilla have always been successful in my hands. This is a case that, of course, a little bit of a stretch of the technique in which the implants are placed laterally, and then the block is put to cover or to create that buccal plate. Primary wound closure. It's just follow-up CT scans showing that there's a nice formation of bone around it. But more than anything, if you see that there's a cortical shell, and then there's cancellous bone within. So I like to recreate nature. Instead of just having this mass of mineralized material within the ridge, you have it form or layer in a way that resembles alveolar bone or natural bone. So, of course, if you have a narrow defect and you can change that into something a little bit with more regenerative potential, that's always also beneficial. Ridge splits are not new. This technique has been around for a long, long time. But I think nowadays we have the materials that we needed back then to make this a more successful procedure. So this in combination with piezoelectric devices and the barrier membranes and the grafts that we have available can actually lead to very successful outcomes nowadays. The advantage of that, of course, it's a one-step procedure. You don't have to graft first and then place the implant later. So in conclusion, I think the most important things to take home are that quality is more important than quantity. You really need to worry about the quality of bone where you're placing your implants. Graft selection should depend on the defect morphology, and combining the properties of these materials is better than mixing them together. Based on that, I think you always should consider having a variety of materials in your inventory for the different clinical situations that we treat every day. Okay? Thank you for your attention.